I just finished interviewing the CEO of Eledon Pharmaceuticals, and did you guys know that Eledon has 5 patients with type 1 diabetes that are completely off insulin? And we talk all about it in the interview. I'm going to show it to you guys now. Enjoy. Can you share with us the most recent, up-to-date, where we're at currently with the breakthroughs of your type 1 diabetes program, including how many patients in your trial have become completely insulin independent?
We've publicly presented on the first 3 subjects, the first 3 patients that were transplanted. And what was exciting was that all 3 of the patients were able to get off insulin, and so they're all insulin free today. We're able to see quick reductions in the amount of insulin that patients need, so that they can see very quickly a reduction of their needs, typically within weeks. We are dedicated to type 1 diabetes and to helping in whatever way we can. As I mentioned, type 1 diabetes is in the DNA of this company. When we founded Eledon, the original data that we generated in transplantation was in T1D. And the first transplantation study that we launched was an islet cell transplant study. So this has been at the core of our focus from the beginning and will very much remain at the core of our focus moving forward.
So for the last 25, 30 years, tacrolymus has been the standard immunosuppressant in islet cell transplantation, but many clinicians and patients recognize that it comes with significant challenges, and those include beta cell toxicity. These cells that it's supposed to protect, it's actually toxic to these cells, which is crazy. You can increase the infection risk. There's long-term effects like being toxic to the kidney and nervous system, as we discussed, and terrible tremors. These tremors are debilitating for many people, as well as leading to hypertension and insulin resistance over time that does require insulin replacement. So having said all that, could you walk us through why you think tegoprubart might have a safer and more effective alternative for people with type 1 diabetes based on the data you've seen so far?
When we founded Eledon and brought tegoprubart forward or into transplantation, our goal for allotransplantation, so that's for transplant between a human to another human, was to replace tacrolymus. And the reason why we wanted to replace tacrolymus was multiple-fold. The first one has to do with the side effect profile of tacrolymus, which you've just mentioned. Tacrolymus, and calcineurin inhibitors more broadly, while they helped open modern transplantation medicine and make it possible, come with a wide range of side effects. In particular, they are toxic to the beta cells of the pancreas that make insulin.
Can you share with us the most recent, up-to-date, where we're at currently with the breakthroughs of your type 1 diabetes program, including how many patients in your trial have become completely insulin independent?
The study is funded for up to 9 or 12 patients. To date, there have been 6 patients enrolled, and so that have received an islet cell transplant and are receiving tegoprubart as the cornerstone of their immunosuppressive regimen. And we've publicly presented on the first 3 subjects, the first 3 patients that were transplanted. And what was exciting was that all 3 of the patients were able to get off insulin, and so they're all insulin free today.
That's incredible that you're already seeing blood glucose control within 48 to 72 hours, as you said.
We're able to see quick reductions in the amount of insulin that patients need, so that they can see very quickly a reduction of their needs, typically within weeks. And then we've even had a patient, one of the 3 patients was able to get off insulin, I believe, within the first month or so. So it can be quite fast.
Studies have shown us that only about 10 to 15% of patients that receive an islet cell transplant with tacrolymus are able to remain insulin independent at the 10-year mark down the road. So based on the data you've seen so far, how confident are you that tegoprubart could improve the long-term durability of insulin independence, and what are the key factors that might drive those outcomes?
What we've seen is that whether it's islet cell function or kidney function, it tends to be quite good and better than what one would expect to see if those patients had been on tacrolymus.
So looking ahead, can you give us a sense of what's next for the type 1 diabetes trial, including how many patients you expect to enroll and the key milestones or timelines you're aiming for? I know you mentioned that there's been an allocation for 12 total patients in Chicago with Dr. Witkowski to be dosed. Is there anything else you can tell us about what lies ahead in this trial?
Sure. So in islet cell transplantation, we actually will have 2 studies that should be enrolling in the near future. The first study is the investigator-sponsored trial from the University of Chicago that we've been talking about. That is now going to be a 12-person study. We have 6 patients enrolled today. We expect to have 9 patients enrolled by the end of the year, and so 12 going into next year. In parallel to that, there is another study launching, another investigator-sponsored study. This one is going to be at multiple centers, including, of course, the University of Chicago, and that will be for patients that have both type 1 diabetes as well as kidney malfunction. And so these patients that have both T1D with kidney disease would be eligible to participate in that trial.
For my own information, my daughter being a 6-year-old patient with type 1 diabetes, if there was approval granted down the road for tegoprubart for the use of islet cell transplant, is there a potential, how does it work exactly? It's going to be 18 to 65 first, and then can they potentially peel back the age as they observe the safety and efficacy profile performing very well? Could they then peel back the age to maybe treat patients of a younger age? How does that process work? Can you speak to that?
So you are correct that our early studies in kidney, in islet cell, as well as in xeno have been in adults, and that has to do with the way drugs are typically developed. We start with adults because the safety bar is higher often with children. So we're starting with adults as well, but our plan is absolutely to expand the use and to do whatever trials necessary so that younger patients, children, may get access to tegoprubart as well.
For somebody with type 1 diabetes, can you speak to what a potential treatment could look like, whether it is an injection, a pill, a subcutaneous shot, and perhaps how often that might have to be taken?
Sure. So today, tegoprubart is taken as an injection. It's an intravenous injection. It starts at the time of the transplant or just before the transplant, and patients receive tegoprubart intravenously every 3 weeks. Our goal, in particular with islet cell transplantation, is to develop a version of tegoprubart that could be injected under the skin, so it would be subcutaneous, to give patients the choice whether they prefer to have a once every 3 weeks or once monthly IV, or inject themselves in the privacy of their home with a subcutaneous version of the drug.